Session 4 is about money and who pays for the work we do in primary care. We provide perspectives from private insurance, employers, patients, and government stakeholders. Enjoy.
Most people, when they go into med school, they just know that doctors make a lot of money. And in med school, you look at these charts of how much each specialty gets paid. Then in residency, you complain about how you get a low fixed amount from Medicare. And then when you leave residency, you're presented with all these contracts about reimbursement arrangements or partnership, like we covered earlier. But very few people actually stop to ask who pays, who is the one that actually holds the money bags. And this is especially important because, as Dr. Eric Bricker likes to say, the golden rule in healthcare is he who has the gold makes the rules. So let's look at who pays for primary care. Predominantly and most obviously is private insurance. Here are some major terms that everybody should know about private insurance. And while this may be obvious to some of you, there's a high percentage of Americans who don't know these terms. So just want to make sure we're all on the same page. The premium is the monthly cost of insurance. It's what you pay to hold the little plastic card. The copay is a made up number that essentially exists just to make you not go to your doctor, or at least to think twice. It has nothing to do with the actual cost of care or the cost of the visit. So, regardless of if you're going in for something simple or something more complicated, copay tends to be the same. And it's usually based on setting, for example, like a $25 copay for primary care, a $50 copay for urgent care and emergency room. The deductible is the amount of money that you have to pay before your insurance company does anything. So if you have a $5,000 deductible, you have to pay $5,000 out of your own pocket before the insurance company does anything, which means that, say your premium is $300 a month and your deductible is $5,000, you would have to spend $3,600 a year in just premiums and then $5,000 in deductibles before your insurance does anything. So you essentially spend $8,600 of your own money in annual healthcare expenditures before your insurance even kicks in. And then when it does, frequently there is some sort of coinsurance. The coinsurance is a shared cost, usually a percentage. So, for example, 80/20, it's what the insurance company will pay for after you reach your deductible. So, you spend $6,000 on a $5,000 deductible at a 80/20 coinsurance. You would then spend $5,000 of your own money and then 20% of the 1,000, so $200 you would owe. Using that same example of the $300 premium, if you had a $6,000 total health expenditure in a given year, you would actually be spending 8,600 plus 200, so 8,800 to have the insurance product plus pay for all your medical services. Insurance is a funny thing in healthcare because when you think about expenditures less than $5,000, you may ask yourself, why are you paying the $3,600 in premiums anyways? And really, if you think about every other industry, insurance exists as bankruptcy protection. It's not meant to pay for the cheap, easy stuff. For example, if you were to use your car insurance to change your oil or to fill up gas, you could quickly imagine a scenario where there's networks of gas stations or places where you get your oil changed. And if you're close to 0 miles on gas, you pull up to a gas station, it's out of network, and you don't want to pay $1,000 for a tank of gas. But then you have to make it across town to get to an in-network gas station, but then your car breaks down and you end up getting towed. That's pretty similar to what's going on in healthcare. This is important because people still use private insurance for primary care. And in general, primary care tends to be pretty routine and low cost relative to the rest of the healthcare system. And yet, private insurance is still the predominant payer for primary care services. However, there are nice little, quote, gifts from the government, and I guess in conjunction with private insurance, such as the annual physical, which is, quote, free, This is basically a head-to-toe glance that a doctor does of your chart and of you. If you utter anything that bothers you, you will get a modifier 25 and then a sick visit tacked onto it. So what you thought was a free visit is actually a charged visit. And then the other thing is there have been multiple studies that show the so-called annual physical doesn't actually do anything, and it doesn't improve outcomes or anything. So really it's just kind of a waste of time, waste of money, but we go through the motions because it makes people feel better. And then of course, the other freebie is preventative services, which anything that has a category A under the United States Preventive Service Task Force is required to be covered by insurance. Of course, this is now called into question as of this recording because a judge in Texas has declared that the coverage of PrEP or pre-exposure prophylaxis for HIV, which is a grade A recommendation under the USPSTF, is contradictory to religious beliefs of an employer. So therefore, they shouldn't have to pay for the cost of PrEP, and therefore forcing insurers to pay for services is unconstitutional and illegal. So we'll see where that goes. But as far as these things go right now, annual physicals and grade A USPSTF are considered free. And speaking of employers, the next payers are employers. About 50% of Americans will receive health benefits from their employers. And this is thanks to World War II when there was a wage freeze. So employers could not compete with each other based on salary. And so they would compete on benefits. And so more and more employers would include benefit packages to get workers to come in. And thanks to that, now almost everybody, well, half of Americans depend on their employers for their health benefits. The thing to know about employers is there's three different types of payments that employers do in order to provide healthcare services. There are different levels of funding. There's fully funded, which is where the employer acts just like an individual on the marketplace, where they pay a monthly premium for their employees and all their employees get plastic cards. No risk sharing, nothing else. The premium money just disappears into the pockets of private insurance stockholders. Then there's the level funded where it's similar. The employer still pays a premium and they get a plastic card, but now they get to engage in risk sharing with the insurance companies. At the end of any period, if the employer is able to reduce the amount their employees use the health insurance product, reduce ER, reduce urgent care, or increase wellness or whatever, then they get half of what they save based on the benchmark or expected cost of that year. Of course, there is downside too. They could potentially lose money at the end of the year. And then self-funded is the highest risk, but also highest reward type of funding where the employer sets aside a pool of money that they use for healthcare claims. And then they have a third-party administrator that kind of sits at the foundation and files the claim and pulls money out of that fund. That way, the employer is not just dumping money into premiums that disappear. They hold on to the money and they manage the risk. And this is where it allows employers to get a little bit more creative. And some of the more forward-thinking benefit advisors in this space can help create customized services using independent, non-BUCA, we call them BUCAs, the Blues, United, Cigna, Aetna, Humana, though Humana is no longer in the employer market. But a non-BUCA TPA, an independent TPA, you can do direct contracting with hospitals, labs, imaging, and a lot of them will work with direct primary care practices or build their own on-site, near-site clinics. So employers can have a big role in deciding what kind of primary care is offered to their employees. And then there is the patient. A small percentage of patients will pay for their own primary care. In the fee-for-service world, you see this in direct-to-consumer. And what I mean by this is more so the things like Roe and Hims and Hers or the virtual telemed urgent cares. that don't accept any insurance. Of course, all the uninsured patients are paying for themselves. And then we mentioned there are these niche specialties like functional medicine that generally aren't covered by any sort of insurance, and patients are paying for that themselves. Under the subscription model, direct primary care and concierge practices are where patients will pay for their own primary care. Direct primary care is where the patient will pay for a primary care subscription and not use any of their insurance. Whereas concierge, they usually pay a membership to be part of the concierge practice, but then they'll usually get billed per visit through their insurance. The final big payer is government in the form of Medicaid and Medicare. Medicaid is for low income patients and some disabled patients, and it is largely run by the states, and the federal government will match. And the matching is state dependent, anywhere from 20% to 50% or more. Medicare is for 65 and above, plus those with end stage renal disease and some disability as well. And this is completely federal. Medicare has parts A, B, C, D. There's a lot of complexity to Medicare, which will be a course in it of itself because of how complex it is. But when it comes to government payers, some of the biggest complaints are it doesn't pay well and there's a ton of regulation. A lot of practices won't take Medicaid despite, and that was one of the biggest pushbacks with Medicaid is expansion is that, sure, you can expand it, but no doctors are going to take it because the figure that's thrown out a lot is that Medicaid usually pays about 60 cents to the dollar. Plus, given the patient population for Medicaid, they tend to be ones who are a lot sicker and harder to deal with. For Medicare, it's the same deal. In the last year, Medicare cut their physician reimbursement by about 4%, even with the 11% inflation. And so most people are not thrilled with how that's going. Of course, there's a lot of excitement in the Medicare Advantage space, but that's a completely different conversation altogether. As you can see, there are multiple payers. It's not all just private insurance, and each of the payers have different wants and needs and have differing levels of flexibility in terms of how they can shape primary care and what they're willing to pay for primary care.
To summarize, we learned about the financial mechanisms related to the practice and access to primary care from the lens of private insurance, employers, patients, and the government. This concludes session 4.